Good morning, everybody. Welcome to Grand Rounds. I think I know most of you. So I'm Tony Killeen. I'm a professor of lab medicine pathology here and director of the clinical labs on the East Bank. And the topic I'm going to talk about this morning is biological variation and its role in lab medicine and how we can go about measuring that. And get my thing to advance here. There we go. So just by way of disclosure, so I have grant support from the CDC for the NHANES study and from NIH for a number of NIH-funded trials which are run through the ARDA lab, and I'm the lab PI for some of those trials. I have no other financial disclosures relevant to this talk. I'm not going to discuss any off-label use of drugs. So there's a famous phrase that variety is the spice of life, and when I wondered where did this come from, it's actually from a poem by this guy named William Cowper called The Task, which dates back to 1785. So he says, variety is the spice of life that gives it all its flavors. That's kind of the theme of this talk today. So biological variation. So when we measure in a quantitative way some analyte or measurand in a clinical lab assay, we get different values from individuals. And we can think about that variation in two different ways. One of them, and maybe the more obvious one, is the between individual variation, which in the terminology of this field is known as the CVG, meaning the coefficient of variation at the group level. And that's defined as the population standard deviation divided by the mean. So different people have slightly different values, and sometimes they're more than slightly different. And these are attributed to different set points between subjects based on things like age, gender, the diet that they're taking, their lifestyle, any drugs or alcohol, genetic factors, collection times, etc. And just to give a couple of examples of this, this is a set of data from an NHANES study back in the early 2000s, and it just looks at hemoglobin A1C levels in different populations of children, and you can see that there are slightly different mean levels of hemoglobin A1C among non-Hispanic white children, Mexican-American children, and non-Hispanic black children. And whether those are attributed to genetic factors or diet or other factors isn't clear in this, but just to show that at a population level these differences exist. And then this is a more recent data that I just picked off from the CDC. Again, I believe these are based on NHANES data sets. So this is looking at the prevalence of high cholesterol in different counties in the United States. And the darker the shade of green, the higher the prevalence of elevated cholesterol. This is in adults. And you can see that, across the southern, southeastern part of the United States, there tend to be higher prevalence of high cholesterol than there is, say, in the mountain region or out on the West Coast. And Minnesota actually has fairly low levels, very low percentages of elevated cholesterol. But just some examples of differences in cholesterol levels among different individuals. And we actually use those population level data to establish reference intervals for most clinical lab tests. And the most common way of defining the reference interval for a clinical lab test is based on the central 95% of the distribution of the values. And if they're not normally distributed, then typically we'll do a log transformation or some other transformation to get them into a more normal shape, and then we'll take the mean and standard deviation of that. So these reference intervals are usually intended to be applicable and representative of the entire population. And as I'm sure most of you are aware, there has been a move away from specifically race-based reference intervals in recent years. And the best example of that I can think of is the change in estimated glomerular filtration rate reporting as of last year, when there were recommendations to drop race, for example, as a factor in the EGFR equations and the new CKD-EPI equations. Now, another level of biological variation, and the one that I'm going to be mostly focusing on in this talk, is within individual variation, which is to say that if you repeatedly perform a quantitative lab measurement on the same individual, you tend to get different numerical results. This is collecting samples over time. And that is expressed in the terminology of this field as the total CV, which is the standard deviation divided by the mean. And that total variation is derived from several sources. One of them is just pre-analytical factors. So if you delay analysis time, if samples are cooled or not cooled on their way to the lab, those kinds of things can impact the measured value. But assuming that those are controlled because you're following a protocol, then we assume that pre-analytical factors should be fairly negligible. And then the other two factors that are important in looking at within individual variation are the analytical variation, that's to say the imprecision of the instrument itself, the assay itself, and then the biological variation, which is indicative of small fluctuations around our homeostatic set points for a given measurand or a given analyte. And again, this is defined as the CBT, which is the sum of, using this square, we're adding together variances. It's the combination of the variance due to analytical. I'm going to try and get myself a pointer here. The analytical, there we go. The analytical variation, and then this biological variation here, which is described as CVI. So that's kind of the background to thinking about variation in an individual person. So why is this biological variation, and again I'm talking here about within subject biological variation, why is that of interest? And it's of interest for several reasons. One of them is in just deciding the level of analytical performance that's required of analytical measurement equipment. And there was a big conference that was held in 2014 called the Milan Conference, which looked at factors that would be useful for defining analytical performance, and biological variation came up there. I'll talk about this in more detail in a later slide. It's used to describe something called the index of individuality, which looks at a comparison of the variance within an individual to the variance within the group or within the population, and I'll show you some examples of that. It's also useful for this, I'd have to say, more theoretical than applied concept called the reference change value, which is to say how large of a change between two measurements constitutes a level that you might consider to be clinically significant. In other words, it might indicate some disease process in the individual subject. And all of these concepts we use to some extent in clinical lab. The person who's probably most responsible for developing this field back in the 1970s and 80s was Dr. Callum Fraser, and Dr. Fraser was a clinical biochemist in Dundee at the, I think, University of Dundee Hospital. He worked there, and he sort of developed this field along with others, but he's sort of the pioneer of this in this field, and he's still alive, and actually I think is still publishing in the field today, many years later. So to go back to this Milan conference, this was run by the European Federation of Lab Medicine in 2014, and it was a consensus conference, and the objective was to describe how to specify analytical performance specification and how to identify what were the best measures and how to define how precise do assays need to be. And they recognized three levels on which that kind of assessment could be made. The first one was looking at clinical outcomes. In other words, looking at the impact of analytical performance on an individual patient outcomes. That's a very difficult thing to do because clinical outcomes are rarely dependent solely on a clinical lab test. And in order to do that kind of experiment, you'd almost want to run a randomized clinical trial where some patients get results from method A and some patients get results from method B, where the two methods have different levels of performance and determine whether there's a difference in clinical outcome. And obviously those sorts of trials are impractical and nobody's going to fund those sorts of trials. Also, you could look at indirect impact on clinical classifications by running simulation studies. These have rarely, if ever, been done. This concept of basing analytical performance specification on clinical outcomes really has not gone anywhere. What has been successful, however, is looking at biological variation. And here the idea is that the analytical noise or the analytical imprecision and bias should be much less than the biological variation itself. And since we can measure biological variation, it's possible, therefore, to get some handle on what the analytical allowable variation should be in clinical assays. And then the final level is just based on state of the art, which is to say we use whatever the best methodology is that we have available. And there's a nice paper by Sverre Sandberg published in Clinical Chemistry and Lab Medicine a number of years ago, describing the results of this conference. So the desirable goals for imprecision and bias that the group established were that the analytical imprecision, I spelled that wrong, should be less than 0.5, less than a half of the biological variation, and the bias or inaccuracy should be less than a quarter of the combined variance within individual and between individuals. And just a reminder, especially to our trainees, that analytical imprecision is measurement of random error that takes place in measurement systems, and bias or inaccuracy is a systematic deviation from what the value should be. So the index of individuality then is the second of the items that comes out of biological variation. And as I said earlier, this compares the within-person biological variation to the between-person or the group biological variation. And it's defined as the variance of within individual divided by the variance within the group. And the concept here is an interesting one, and that is to say that if the within-person variance is low, then the reference interval, which is based at a population level, is less likely to be useful for result interpretation. So let's say that we have an analyte or a measurand where at an individual level there's a really small biological variation. In other words, it's really tightly controlled physiologically, but between individuals within the population there's a wider range. So if we take the population-based reference interval, then a given individual may move way beyond his or her personal reference interval, so to speak, yet still be within the population reference interval. And so the population reference interval may be less useful for identifying clinically significant fluctuations within a given individual. On the other hand, if the index of individuality for an assay is high, and the case defined somewhat arbitrarily is greater than 1.4, then the dispersion of values within an individual is more closely represented by the population reference interval. And to sort of make this a little bit more concrete, here is a slide with data from David Lacker, which was published in Clinical Chemistry a number of years ago, but just comparing the biological variation within individual for a number of analytes to that between individuals or within group. And you can see that, for example, alkaline phosphatase has a pretty low index of individuality. The biological variation within an individual is only on the order of about 4.4%, whereas between individuals it's more like 33%. So in that case, it's got a low index of individuality. We have to use, for practical purposes, we have to use a reference interval that's based on the entire population, but you can see that an individual may have a significant, for that person is a significant rise or fall in alkaline phosphatase, and yet it might not be reflected as moving outside of the population reference interval. On the other hand, at the other extreme, you've got sodium, where the biological variation of sodium intra-individual is about 1.3% and not much larger between individuals. And so the index of individuality there is higher. So the concept here is biological variation can inform this index of individuality. And that kind of leads on to the next concept, which is the so-called reference change value. And that's to say, if we look at serial measurements within an individual, what level of change do we consider to be statistically significant? And there is a formula that's used to calculate this. So you take the square root of 2, multiply it by either 1.65 or 1.96, depending on whether you're looking at a one-tailed or a two-tailed change. To exceed 95% probability of occurring by chance, you multiply that by the total CV, square root of that, and you come up with a number which says that given this biological variation, this particular change is more than would be statistically expected or less than statistically expected. And so, again, this kind of ties in with the same concept as the index of individuality. This reference change value might provide more useful information about an individual patient than looking at a population-based reference interval. Now, the problem with this, of course, is that for most people, we have no idea what their individual levels of any analytes are unless we're sequentially monitoring them, which we're not for healthy people. So while in theory this is a useful tool, and maybe with personalized medicine is something that might be adopted more widely fluctuation around their set points, which currently is just impractical for obvious reasons. So how do we calculate the within subject biological variation? I think the first thing to say is that there's currently no universally accepted protocol. There are some guidelines, but they leave a lot of wiggle room. The traditional way of doing this is to take so-called healthy subjects who are maintaining their usual lifestyles, and then you sequentially over time monitor whatever it is you're interested in and come up with a variation, a level of variation in that subject. Now, there are a lot of practical questions here. Do we exclude people if they're taking medications? Do we exclude people who are taking alcohol or other drugs or smokers? How many people need to be included in these kinds of studies? Because of cost reasons and practical reasons, these tend to be limited to relatively small groups. And there's this proposal that as few as 10 individuals per subgroup, such as females and males, can be, quote, good. Samples are collected sequentially, and then the duration of the study should be appropriate to whatever length of time you're interested in. If you're interested in biological variation over the course of a few days, then that would be the appropriate sort of interval for collecting samples. If you're interested in biological variation over months or years, then obviously we need a much longer interval between sample collection. The collection and transportation of the samples to the lab should be standardized. Ideally, you would freeze all samples and then analyze them all in one go in the lab in order to minimize the analytical CV. So the analytical CV would be minimized if all the samples were run in one batch rather than having them run every day that samples showed up in the lab. And then ideally, again, you should analyze all samples in duplicate, and that would give you some handle on what the analytical CV is. The statistical approaches to doing this sort of analysis, there are two major approaches. The traditional one is analysis of variance, and that is still recommended by some authors for doing biological variation studies. So analysis of variation partitions the variance into between individual, within individual, and the analytical components. A more modern method is to do a mixed effects regression, linear regression model, and that has some advantages for repeated data measurements, especially if some data are missing or the timing of collection is not consistent. So if some participants are missing data, then ANOVA tends to sort of just drop those from any consideration at all. And if the timing of collection is not consistent across every participant in the study, then again, ANOVA tends to drop those participants, whereas mixed effects linear models can incorporate them, just knowing what the actual time is when the samples were collected. So there are a lot of limitations to existing biological variation studies. They tend to involve small numbers of subjects. Subgroups are not frequently analyzed. And for practical purposes, they're often performed over relatively short time frames, such as days or weeks. And if we want to apply these to clinical scenarios where patients are coming back for, an annual physical exam or much longer duration of time like that, I think these short-term biological variation studies are not particularly informative. So there was an effort by Carmen Ricos, who is a Spanish clinical biochemist, and from 1996 onwards, she and her colleagues maintained a database of published biological variation studies, which was available on the web. However, over time, there was more and more concern about the accuracy of the data. Not that they weren't curating the data correctly, but just the data that they were gathering itself was inaccurate because the studies were not that well designed. And so the European Federation of Lab Medicine took over this curator function, and they began to perform organized, updated biological variation studies for many common clinical chemistry and hematology analytes. And they also produced what's called the Biological Variation Data Critical Appraisal Checklist, which is used for assessing biological variation studies. And this checklist contains 14 items, and they're ranked in importance from A to D. And so you go through a biological variation study and you apply this checklist and you sort of check all the boxes and give them rankings on the items in these 14 elements. And each biological variation study therefore gets a kind of a score in terms of its quality and reliability before it goes into this biological variation database. And then, just since I'm going to be talking about creatinine later on, this is the this is the current status of creatinine. There are the biological variation for the intra-individual variation is estimated to be 4.5%. With a lower confidence interval and a higher upper confidence interval limit shown there. And then between individual or the group, biological variation is a lot higher. So, you know, there are big differences between males and females, for example, for creatinine, which explains why, partly explains why the group biological variation is so much higher than the within subject biological variation for creatinine. And these were updated as of just yesterday. And then if you look at this database, they, by the way, these numbers come from an overall meta-analysis where they went through all the higher quality studies, and these are the results of the meta-analysis. These manuscripts here, or papers here, are the raw numbers, and you can see there's some variation there. So this one, for example, I think this one down here, actually, this was written by Dr. Eckfeldt in our own department back 1994. These were the within subject variation for creatinine and the between subject variation. And again, these used healthy individuals, excluding pregnant patients. There were some other studies that come up with somewhat higher numbers, and the meta-analysis I showed you is the aggregate of all of these. So that's one way, is to do a biological variation study, is to do a formal study where you collect healthy volunteers and just draw them over time and calculate the biological variation. There have been several efforts made to estimate biological variation using existing large data sets. And one of the earlier ones of these was Lacker in 2010, who again used data from the NHANES 3 study and looked at within and between person biological variation in 34 common clinical lab measures. So the NHANES surveys people in the US population. It's meant to be a fairly random sampling of individuals, different ages, both genders, and there's ethnic data collected as well. So it's a useful database for this kind of application. They had as many as almost 19,000 participants, and of those 19,000 people, there were 853 who had repeated values. And so I think so they used these repeated values. What was notable, I think, here was there were only 2 repeated samples in this large number of subjects. The average time between the measurements was almost 3 weeks. And they showed that there were gender differences for 10 analytes. And if you want to see more about this, it's written up in this article here. More recently, Lowe, who I think is in Australia, looked at hospital records. So they looked at 22 analytes that were measured in a pediatric outpatient population in Australia. So they included all of the repeated measurements in children defined as under 19 years of age over a 12-month period. And they had almost 7,000 subjects who had at least 2 measurements. There were almost 2,000 who had 3 measurements and 640 with 4 measurements. And they again calculated the total CV, which we've seen this equation before. So the total CV is a combination of the analytical CV plus the biological variation. And what they showed was that the biological variation, of course, varies by different analyte. And it also, interestingly, varies, this is again, it's a pediatric population, by age. So you can see that in young children, just to take an example here, their creatinine levels has much higher within subject variation in infancy than it does, for example, when they get to be teens. So there were some interesting findings from that study. But the point here is that this is analysis of hospital records. And of course, using an outpatient group, because outpatients are assumed to be generally more healthy than, for example, inpatients. So Graham Jones, also in Australia, did a similar thing, looking at data in his hospital database, and he looked at 26 different analytes in clinical chemistry and hematology. They got the analytical CV from the lab quality control records. They were able to use this thing called a Bhattacharya analysis, which, when you have a large population of a large group of data, Bhattacharya analysis is a method of picking out what seems to be a Gaussian or a normal distribution. And he also looked at age and gender and time between collections and compared his findings to those that were in the published, the RICOS database. And so this on the y-axis here is plotted the biological variation as he determined from his outpatient study, and the biological variation is reported in the RICOS database. And if they're equivalent, then the points should fall on this dotted or dashed line. And you can see that generally there is a pretty good agreement between what he found in his hospital outpatient setting versus the more formal published studies which were in the RICOS database. And so I think this sort of study shows that it's possible to use large data sets, including hospital data sets, in order to come up with measurements of biological variation, which is useful. Now, this concept has taken hold in this project called the Athlete Biological Passport. So the ABP is a program that's actually run by the World Anti-Doping Agency, and it involves serial monitoring of elite athletes' lab test results. So if you're an elite athlete, and that means somebody who's in high-level competition for things like cycling, running, track and field, soccer, and so forth, then you may be required to participate in this biological passport program. So what they do is they build up a sort of profile of your biological variation in a number of measurements, specifically hematologic indices and androgenic steroids. So that the heme stuff comes from blood collections, and the androgenic steroids comes from urine measurements. So you're required to give a small sample of blood periodically, and you're required to give a urine sample periodically. And so they build up a database by collecting these things over some period of time, and they can establish for each athlete what is his or her kind of biological variation for these different markers. And again, just to point out that this is not a drug screen. We're not actually looking for drugs here, but rather we're looking for the changes in physiologic markers that might come about as a result of taking androgenic steroids, for example, or blood doping, or administration of erythropoietin. All of these have been used and are used by athletes who basically are cheating in terms of gaining physiologic advantage. So any significant change from usual values suggests that there is an external factor at play, and that might be a blood transfusion, including the athlete's own blood, administration of EPO, erythropoietin, and androgens. And so if the results come back showing a significant deviation from expected, then that will lead to more intensive testing of that athlete and further investigation. And as I said, it's used for monitoring elite athletes in many sports. So these are the hematology variables that they follow in this athlete biological passport program. So just stuff that we report every day in our lab: hemoglobin, hematocrit, reticulocytes, and so forth. You can read these things here: platelets, white cell count. There's this score they calculate called the OFF score, which is the ratio between the hemoglobin and the reticulocytes. So they take the hemoglobin and divide it by, it's not quite a simple division because there's some other factors at play here, but it's basically a ratio between hemoglobin and reticulocyte fraction. And if any of these are perturbed, then it suggests that something has changed about that athlete. And this is from the literature that's provided for the athlete themselves, and they tell you that if you start to compile a profile of blood parameters, and they tell you, of course, that these can vary between individually and genders. We know this. And then there are factors that can change an individual's profile, such as altitude training, sleeping in a tent. I think that means either a low or a high oxygen tent. I'm not quite sure how they do this. Recent hard training, recent heavy blood loss or transfusion. So if you've had any of these as an athlete, you have to explain all of this at the time your sample is collected. And then they look at these results, they come back, and the judges in this case can rule that if there's a deviation, that the athlete has no case to answer, or they request more targeted testing, which can include looking for specific agents, or they can unanimously agree that the only possible explanation for the deviation in your result is that you're using some prohibited substances or methods, and you can be sanctioned with an anti-doping rule violation. And these anti-doping rule violations can be pretty severe. So I think at a minimum, it's a 2-year ban on participating in high-level competition. And for repeat offenders, I've seen, because this is all available on the website, for repeat offenders, it can be as long as a 12-year ban, which basically for these elite athletes is the end of their athletic career. I mean, 12 years is a huge amount of time to go by. For the urine steroid part of this, these are the compounds they measure, so androgen steroids, and they also take a bunch of ratios, so testosterone to this epitestosterone ratio. You can see the other ones here. So they look at all of these things, and if you're taking exogenous androgenic steroids, these ratios will be disturbed in one way or another. So that's kind of a specific application of biological variation in the context of looking at and monitoring elite athletes. So I mentioned already that people have looked at biological variation as a result of formal biological variation studies where you recruit people for a biological variation study. They've looked at them in databases like the NHANES studies, and they've looked at them in hospital databases. And there's yet another way that you can get a handle on biological variation, which is the one that I was interested in, and that's looking at clinical trials. So as I'm sure most of you are aware, the ARDL lab in our department is the central biochemistry lab for a large number of clinical trials that are run across the United States. And the trials that we're involved in all involve some longitudinal measurement of biomarkers under very carefully controlled conditions. So it's sort of an ideal context, I think, in which to do biological variation studies. These are also linked to very carefully curated clinical and outcomes data. And the one that I'm going to talk about specifically is the SPRINT hypertension trial, which began in 2009. The main part of the trial ended in 2015. We were the trial central lab, and we did most of the lab monitoring for the SPRINT hypertension trial. And I looked at the biological variation of creatinine using the trial data. So just a quick background about the SPRINT and the burden and hypertension itself, which was the main purpose of the trial. Not to do biological variation studies, but because the trial itself is very interesting. At least 80 million people in the US have high blood pressure, which represents at least a third of all adults over using the 140, the traditional 140 over 90 millimeter mercury blood pressure definition. And among African Americans, about 45% have hypertension. And worldwide, it's estimated that 1 billion people have high blood pressure. So these are data from, I think this is also NHANES data. So just looking at the percent of the population that has high blood pressure by age and by gender. So you see that, as people get older, the prevalence of hypertension increases. In younger populations, it's more prevalent somewhat in males, represented by the blue bars, than in females, represented by the red bars. But after about 65 years of age, when you get into older age groups, it's actually slightly more common in females than it is in males. Okay, so the general protocol for the SPRINT trial was that there was a 2-year recruitment period with a maximum follow-up planned of 6 years. They planned to enroll over 9,000 people. The participants and the treating physicians knew their target BP goal, so it was not like a double-blinded, it was an open trial. The adjudicators, however, for events were blinded to what the patient's blood pressure target was. So trial participants randomized to a systolic blood pressure of either less than 140 millimeters of mercury, which was the standard therapy, or less than 120 millimeters of mercury, which was the intensive therapy. Of course, like any trial, there was a data safety monitoring board. The trial was funded by the NIH, and I think the NIH spent something like $150 million on this trial. It was I think at one point it was the largest single expenditure of funds by the NIH during some fiscal year. So to get into the trial, you had to be at least 50 years of age, you had to have a systolic blood pressure between 130 and 180, and you had to have an increased risk of cardiovascular disease, so either known clinical or subclinical CVD other than stroke. If you had stroke, you weren't eligible. Chronic kidney disease, a 10-year risk of cardiovascular disease of at least 15% as determined by the Framingham Risk Score, or age at least 75 years of age. So any one of these were considered to be increased cardiovascular risk. And the reason that they sort of enriched the trial population with people who were at increased risk for cardiovascular disease was their big fear at the outset of the trial was that there would be so few events that they wouldn't be able to come up with a statistically valid conclusion. So you need to have events in order to get statistical validity on a trial like this. So they excluded also anybody who had diabetes at baseline, and the reason for that was that another similar trial called ACCORD had just ended, and they didn't want to reproduce a similar trial, meaning similar, looking at the same levels of blood pressure control and outcome, and they didn't want to reproduce it again in diabetic patients, so they excluded diabetics this time. And as I mentioned earlier, if you had had a stroke, you weren't eligible for entry. The medications that were used were standard therapies that are used to treat patients with high blood pressure. So patients were seen monthly for the first 3 months, then every 3 months after that, and medications were chosen according to the trial protocol to get a blood pressure of either less than 140 or less than 120. And just for interest, the number of blood pressure medications in the standard and intensive groups were 1.8 and 2.8 respectively. In other words, people in the intensive group, that's to say the less than 120 systolic blood pressure, were taking almost 3 antihypertensive medications compared to 2 in the standard group. So the outcomes that they were looking for, the primary outcome was a composite of myocardial infarction, acute coronary syndrome, stroke, decompensated heart failure, or death from any cardiovascular cause. Secondary outcomes were the individual components of the primary outcomes. And then there was a separate group looking at renal outcomes. So if you had CKD at baseline, it was a composite of a decrease in EGFR by 50% or development of advanced stage renal disease requiring dialysis or kidney transplant. If you didn't have CKD at baseline, then it was a 30% drop in EGFR to a value less than 60 mils per minute, or the development of incident albuminuria. So a doubling of the urine albumin creatinine ratio from under 10 to at least over 10 at follow-up. And there were pre-specified groups of interest: baseline cardiovascular disease, yes or no; baseline chronic kidney disease; gender; race was considered; age, less than 75 or older than 75; and then starting blood pressure, as in those 3 categories shown there. I'll skip that one. There were 102 trial sites around the United States, and here we are the central lab. There was an MRI reading center in Pennsylvania, there was an EKG reading center in Wake Forest, and there was a drug distribution center in New Mexico. So this is the blood pressure according to time. So you can see this is years on the x-axis, here is systolic blood pressure on the y-axis, and you can see that within the intensive treatment arm, within a few months, they got down to their goal blood pressure of 120 or thereabouts. And the standard arm, there was a clear separation by 3 to 6 months between the 2 groups. So the bottom line of the study, what was the outcome? So in the intensive treatment arm, there were 4,678 participants. Remember, we're randomizing about 9,000 people. Of those 4,600, 243, or 5.2% in the intensive treatment arm developed a primary outcome. And in the standard treatment arm, which has a similar number of people, there were 319 outcomes, or 6.8%. So the fewer outcomes in the intensive treatment than in the standard treatment, and that corresponded to a hazard ratio of 0.75, in other words, a reduction in the risk of a primary outcome in the participants in the intensive treatment arm. And then in the people who had, looking at the renal outcomes, in the people who did not have CKD at baseline, now remember there was a special group that was recruited because they had CKD at baseline. So there were a total of about 6,600 people who did not have CKD at baseline. And of those, 3.8% in the intensive treatment arm had a drop in eGFR to less than 60 versus 1.1% in the standard treatment arm. And that was a very significant difference. So being on the intensive group, you were at greater risk of developing a decline in estimated GFR. That was considered a lot by the trial organizers, and the thinking was that much of that was reversible. It happened during the initial phases of treatment when blood pressure was lowered, and people whose renal function may have been somewhat compromised to begin with, as their blood pressure lowered, they had reduced renal perfusion, and so their eGFR went down somewhat. But they weren't overly concerned with this difference, although it was significant. If you look at incident albuminuria, there was no difference between the intensive and the standard arms. That's a non-significant p-value. Okay, and just to sort of wrap up this clinical part of this, the trial, the number of people needed to treat during the years of the study to prevent a primary outcome were 61, to prevent death from any cause 90, and to prevent death specifically from cardiovascular disease 172. And I should say, by the way, that the 3.26 years of monitoring was because the two groups began to diverge after a few years, and the Data Monitoring and Safety Board looked at the data and said, well, clearly there's an advantage to being in the intensive arm of the trial versus the standard arm. And so they actually cut the trial short. It was planned to go for 5 or 6 years, and the Safety Monitoring Board said, you've proved your point, and so the trial got cut off shorter than was anticipated. Okay, so biological variation in sprint. So here we have this really carefully collected set of samples with excellent clinical outcome in terms of the curation of that clinical outcome, the accuracy of that clinical outcome. And we and Arnold measured all of the blood creatinines and many other analytes for this particular population. So in my view, this was a stable group of treated hypertensive patients. And so rather than looking at biological variation purely in healthy individuals, how about looking at biological variation of creatinine in this case, which is the analyte I was interested in this stable group of people who've got such a common disease? What does biological variation of creatinine look like in hypertensive people? Does it differ from previous reports in healthy subjects? And are there age, gender, and ethnic differences in biological variation in this sprint cohort? And does increased biological variation precede a CKD outcome? So Sprint collected creatinine samples at baseline and then regularly, so 1, 3, 6, 12, 18, 24, so on months after randomization. And the ones shown with the asterisk were collected at the fasting state. All of the lab samples were shipped from their collection sites overnight on ice to the central lab. Again, that was Ardle. They were all run on the Roche chemistry analyzer. We did actually switch instruments during the middle of the trial, but the methodology, the analytical methodology in terms of reagents and whatnot, stayed the same. So it was pretty consistent for the duration of the trial. And it was using an enzymatic creatinine method. And looking back over the analytical quality control records, I was able to establish that the analytical CV for creatinine during the course of the trial was 2.7%, which is sort of expected. So I looked at creatinine biological variation. This is just a quick sketch of the mathematical approach here, where I determined variance components using a mixed effects model with random intercepts and random slopes. And the analytical CV, as I mentioned earlier, came from review of the lab QC records. And this is the formula here to get biological variation from the total variance of measurements over time. You subtract out the analytical component. Just to give you an idea of the number of samples per subject during the trial. The most individuals had about 10 creatinine samples measured during their time while they were in the trial. These were the number of creatinines that we measured by month during the trial. So this is baseline, 1 month, 3 months, and so forth. And you can see that there are fewer out of the far end because the trial ended. So not everybody who joined the trial later, for example, spent 3 or 4 years in the trial. So these higher values would represent people who were recruited somewhat earlier to the trial. By the way, just as a note here, I did a back of the envelope calculation, and I think that ARDL contributed something like 1 million data points to this trial. So we were a huge contributor of information. These are mean creatinine values by month during the duration of the trial. So I've got one of these zoom markers right blocking my view of what I'm trying to show here. So the red is females who had CKD at baseline. The blue is females who did not have CKD at baseline. Males, CKD in the purple, who did not have CKD at baseline. And the green is males who did have CKD at baseline. And as we know, creatinine in men tends to be slightly higher than creatinine in females. But the point here is that these values were pretty stable on average during the course of the study. There's a slight increase over the period of the trial on average, which is expected because these people were obviously aging. As you get older, your creatinine level tends to rise a little bit. These were raw creatinine values shown here. This is the total population. If I looked at individuals who had creatinine values of less than 5, this is what the distribution looks like. You can see it's skewed to the right. As you'd expect, this normal curve here is overlaid, and you can see the data really are not normal. If we took log transform the creatinine values, which is what's shown here, then we get a more normal distribution, and that's shown by this so-called QQ plot. It's not ideal. If it was absolutely normal, all those points would fall along this black line here, but it's reasonable, and the statistical methods are reasonably robust to this kind of deviation from complete normality. One thing that comes up with biological variation studies is if you have outliers, how do you handle those? And the recommended approach is to not exclude outliers unless it's very obvious that there's simply a mistake in recording data or something else clearly has gone wrong. But if you have no idea why a patient is an outlier in terms of any measurement, the recommendation is to keep it in. You can also remove them and just sort of do the analysis both ways, with and without the outliers. So these are just some more statistical stuff. I'll get to the bottom line here. So if we excluded observations based on outliers, we would have excluded about 400 observations, not people, but just observations, or 0.7% of the total. So there were a total of 54,500 observations if we did not exclude anybody based on outlier, and 54,100 if we excluded based on outliers. Outliers meaning, in this case, they were defined as more than 3 standard deviations away from what was expected. So the total variation that we saw in creatinine without outlier exclusion was 8.8%, giving a biological variation of 8.4%. So some of that addition, of course, is the analytical variation, which I told you was about 2.7%. And if we did outlier exclusion, then the biological variation dropped to 7.3%. And sort of to put that in context of what would that mean for a reference change value for 2 consecutive results, we come up with about a 22% change being significant if we did outlier exclusion and using a 2-sided test. So sort of I'll come back to this in context in just a second here. So again, the answer to the question is, what's the biological variation in this population? And the answer is it's somewhere around 8.4% if we don't exclude outliers, and 9.9% if we exclude outliers. And I'm just going to quickly go through some slides here. There were the variation, interestingly, and this has been seen in other studies, the biological variation in females is slightly higher than it is in males in creatinine. This is seen not only in this study, but it's also been reported in studies of normal individuals. I'm not quite sure, I don't know if anybody knows why that is, but females tend to have higher biological variation. Biological variation was also higher among Black participants than non-Black participants. And among those who went on to develop chronic kidney disease, of course, their biological variation is higher because they're sort of trending towards having a CKD outcome. But even before they reach that threshold of a CKD outcome, it's possible to identify people as having increased biological variation who are on their way to having a CKD outcome, and it's certainly higher than it is among the group of people who don't have a CKD outcome. And again, I sort of put this back in context of this data that I just pulled up yesterday on biological variation that's reported in the European Federation of Lab Medicine database. So their median is 4.5%, and I'm showing that in an adult population with high blood pressure, the biological variation is essentially double that. So I think it brings into question, when you're thinking about biological variation in clinical context, is it appropriate to use data that are derived exclusively from normal individuals, or should we be looking at more disease-specific biological variation? And I think that's one of the interesting points. As I said earlier, biological variation has tended to be established in healthy individuals. I think, unlike reference intervals, I think there's an argument to be made that biological variation should be looked at in the context of the patient's overall health, and specifically in the context of patients who've got chronic stable diseases like high blood pressure, that the values that you get in healthy, normal individuals may be much lower than what you see in patients who've got stable disease. So this is, if we look at a reference change value of about 20% on predicting future renal outcomes, it doesn't have a tremendously strong positive predictive value. It's only 7%. It has a very high negative predictive value, but of course a lot of that is attributable to the fact that not many people developed chronic kidney disease during the study anyway, but these are the numbers. So what would a 20% change in creatinine mean? So if we have a 65-year-old female whose baseline creatinine is 1, then her EGFR calculated, actually this is calculated using the older CKD-EPI equation, would be just shy of 60, it's 59. If her creatinine...
Recording stopped.
If her creatinine came back at 0.8, then we would say that her EGFR has gone up by 18. If her creatinine comes back at increased by 20%, then we'd say her EGFR has dropped by 11. So in other words, what this is saying is that you could have, within this specific individual, you could have a range of creatinines anywhere from a drop of, EGFRs, a drop of -11 to an increase of +18, and she would still be within the range that you would expect given biological variation, which seemed kind of wide to me, but that's what the data show. So I think some of the strengths from this study is that the data were collected under conditions that reflect usual clinical and lab practice over long periods of times. There's a large sample size, many thousands of people with good representation by gender and ethnicity. There were subjects with and without CKD at baseline. The creatinine was measured using a very consistent and robust analytical procedure in the ARDA lab, specifically with this enzymatic method with calibration that was traceable to the IDMS standards. And there was very detailed and carefully curated clinical follow-up information. So the point I think I'm making here is that we have access to really high quality data as a result of the studies that we're involved with in ARDL if you want to get involved in sort of biological variation studies. Some specific limitations of this study: obviously it was limited to non-diabetic subjects by study design. The analytical CV had to be estimated from the quality control records and not ideally, as would be ideal, which is to say we do duplicates in the same run. That just wasn't part of the study design, but this is an acceptable way of doing it. So the key points is that biological variation is an element that we have to consider in interpreting quantitative clinical lab results. You don't have to do formal BV studies. You can use hospital records and you can use clinical trial data because they contain a wealth of information that can be used to derive biological variation data. And what we're seeing now increasingly is the use of hospital records to come up with biological variation data. And then in the SPRINT specifically data set, the biological variation was slightly higher, of creatinine was slightly higher among women than men, slightly higher among African Americans compared to non-African Americans. And I think this is maybe the most interesting part, is the biological variation that we observed was nearly double that's reported in the European Federation of Lab Medicine biological variation database. So there were many people who worked with me on this project. So primarily that my study co-investigator was John Eckfeldt. Annie Lukery and Sharon Minerath were study coordinators during the study. Greg Rinders was one of the medical technologists in the Ardle lab, who was just instrumental in getting the study up and running and keeping it running and keeping the quality control on track. Also Jen Peters, Bob Janicek is the manager at Ardle, many other staff at Ardle, and then I had some collaborators at the University of Oxford for this study. So I will end there, and I think we have a few minutes for questions if there are any. I'll stop sharing.
Excuse me, Dr. West has a very interesting question in the chat.
Okay, I'll go to the chat, sorry. Okay, so Dr. West says that some studies appear to account for gender biological variations. Will these trends changes studies include transgenders, or how can we account for transgender? Or will the hormonal therapies cause the same biological variation? That's a fascinating question. So I'm not aware of any studies that have looked at biological variation in transgender individuals. There are a number of studies. In fact, we had a speaker at Grand Rounds a number of years ago who spoke about changes in some clinical chemistry and hematology parameters in people who've transitioned from from their birth gender to the other gender. But I'm not aware of any that have looked at biological variation specifically in people who are now in a different, gender than birth. But that's obviously something that I'm sure is worth doing. And I don't know if we may have samples here from our transgender clinic that one could look at to maybe begin to explore that question, but I'm not aware of published literature in this area.
Question, Tony, this is Andy on that same thing. Again, wondering if it's a broader question in the sense of, what Michelle was getting at is, in fact, actually, that those individuals are taking hormonal therapies, and there's many reasons that individuals take hormonal therapies or a whole host of medications can actually affect many of these biological parameters. So again, just wondering, what's the scope of work to make sure that we've got good metadata about all pharmacologic therapies that patients are taking that can impact these variables?
So the question has come up specifically in the case of transgender, Andy, about the lab providing different reference intervals for transgender patients than the ones that we're currently using. The issue becomes defining what is the appropriate reference interval. For every drug, I think it would just be overwhelming to consider every drug, and almost to the point of currently of being impractical. It would have to provide a reference interval for every conceivable situation. For the transgender specifically, there is a move towards clinical labs reporting specific reference intervals for some markers, like steroids, in transgender subjects. But it's an area that's obviously one of a lot of interest right now. And actually, there was this lecture we had at Grand Rounds a couple of years ago, and I'm blanking on the name of the lady who gave it, but she was from the University of Washington in Seattle. Maybe somebody else can remember her name. Yeah, thank you, Stephanie. Dina Green. Dina Green gave that talk, and she's written about specifically transgender changes in reference intervals. But as I said, I'm not aware of biological variation being studied in that context.
Tony, Dina gave a really interesting talk at AACC with transgender and troponin. And the interesting finding I thought was as they transition, they actually transition, like a woman to a man transition and a man to a woman transition actually correlated with where they transition to. So the woman transitioning to man went with the men's reference interval, which was astonishing. I thought it was fascinating. So there are some interesting things. To speak to the drugs, though, yeah, you're right. I mean, I don't know how you would do that, but I think for some of these things, maybe even like GFR, you could. Some of these studies should be included in that as well too. So.
Right.
Yeah, and just thinking out loud, Jesse, I mean, you know, there are certain classes of drugs, antihypertensives, for example, where, I mean, they're just, you know, and maybe you guys already know the answer for those that are exceptionally common, but there are probably certain classes of drugs. I'm starting to think about this. I don't know if Pavel's on the line, but I mean, it also gets in the realm of PGX, metabolizers. And I mean, it gets to a point where this is just big data and it needs, you know, machine learning algorithms to sort it out for us. It's kind of a cool problem to think about.
Right. So I hate to cut off my own grand rounds, but we have a APCP faculty meeting, a staff meeting here at 9 o'clock, which we need to get going. Is there one other quick question? Oh, there's John. Hi, John. I see John.
Yeah. Hi. A real quick question. Do you think maybe because these were hypertensive subjects that may have influenced the number you got for the biological variability, that maybe, you know,
it's possible, and I mean, I think that, yes, I mean, the study design was these were hypertensive patients on two different two different targets for blood pressure. So I am assuming that, yes, this is at least partly due to the fact that they have high blood pressure. But I think the interesting part, at least to me, is that it's so much higher than in so-called healthy individuals. And if we're going to use reference change values, we need to consider the underlying health condition of the population that we're looking at.
I mean, it might be interesting to look back and where they got that lower number, whether they are younger individuals, non-hyper, you know, who they excluded, you know, maybe.
Yeah, well,
talk with Callum Fraser, he would know, I'm sure.
They were nearly all healthy individuals by design. They treated like they're treating like establishing a reference interval, where you want healthy people to establish a healthy reference interval. Okay, well, I apologize, but we do have to wrap this one up, and so thanks for your attention this morning, everybody.